know, navigating what you want to do as a physician can be difficult. And so I guess, when did you know that you wanted to work in emergency medicine?
Well, it's a good question. I mean, I had a background. I was a EMT and a volunteer fireman in college. And then I actually spent the summers riding ambulance in New York City. So that was kind of my background into medicine. But I tried to go into it with an open mind. When you get to your third year of medical school, you start going through the different specialties. I tried to like everything. I just never really liked anything as much. I definitely didn't like certain fields, but emergency medicine seemed to still do it for me. So that's kind of how I continued my journey in that realm.
Yeah. And how did you arrive from, working in the ambulance to being like, okay, I want to be a doctor. Like, I don't think this is enough for me.
Yes. I think a lot of times in the beginning, I didn't go into college being like, I want to be a doctor. Right. It was like, it seems like a reasonable career path. I'm good at science. I think that's one of the careers. But when I was riding ambulance, a lot of times it was just like not enough. Like I wanted to know what happened to the patients. I wanted to continue to take care of them, and just like dropping them off wasn't enough for me. So, I remember talking to one of my senior paramedics one time. His name was Gordon. I always remember. And I was like, I think I'm going to try and get into med school. And he's like, you don't try things in life, you do them. So I always carried that with me. So that's kind of how that happened. And then I just, I signed up for the pre-med classes and went from there.
And what made you choose the DO program? Because you're a doctor of osteopathic medicine, right?
Yes. That's where I got in. There's no special answer there. I applied to both MD and DO schools, and I got into to the school I went to, and that's where I went.
Yeah. And what was, do you think there's a difference between MD and DO? I kind of know the answer, but I think for everyone to know, I think everyone sees DO or they see MD and they're kind of confused of like, okay, well, are you a doctor, or you are a doctor, but why is it a different name? Like, I guess maybe explain it to people so they maybe not understand.
Sure. So practically speaking, nowadays there's no real difference. There's some difference in how we're taught in school, but a lot of that is really kind of erased in training. So for practical purposes, there are osteopathic physicians in every specialty, and there's no real difference. Now, historically speaking, originally osteopathic medicine was created because by this guy named Andrew Taylor Still, who felt that treating the body rather than the disease, treating the patient as a unit, and that everything is interconnected, and tended to use less medicine and more like holistic care, I guess, so to speak, historically speaking. Now there's really very little difference. We are taught extra skills called osteopathic manipulative medicine, which can be compared somewhat to chiropractic. So there's that additional skill set that we have, which is more musculoskeletal based. So certainly for those of us in musculoskeletal fields that incorporate some of that into our practice, it can be helpful. But again, practically speaking, myself and my MD counterparts in emergency medicine, no difference.
And what is a physiatrist? Because I know there's a lot, even out here, I've seen people who quantify themselves as a physiatrist. I guess what's the difference between that and like a DO, MD?
Sure. Physiatrist is an MD or DO, generally speaking, that specializes in the field of physical medicine and rehabilitation. And that's just kind of what they're called. A lot of them work in rehab centers, and some of them do pain medicine, and some of them do just rehab medicine in general. But they tend to be the doctors in charge of rehabilitating people.
Yeah. And you had talked about earlier, you kind of didn't really like one particular area of expertise. And with emergency medicine, you kind of have to, I'm assuming, know a little bit about a lot. And so primarily with emergency medicine, what are you primarily focusing on? Is it mostly ortho? Is it cardio? Is it, neuro? Like, what are the primary things that pretty much like just discern whether or not, like, okay, I like ortho, I like cardio, maybe I should do emergency medicine?
Sure. I mean, it's a kind of a grab bag. I like to joke that we're the most interesting 15 minutes of every other specialty. But we get, training on everything, right? Because anything can walk through the front door. If our bread and butter, biggest complaints in the emergency department, chest pain and abdominal pain. Those are our biggest, number one, number two complaints consistently. But yeah, we got to know a little bit about everything.
Yeah. And I think when people think about emergency medicine, they're always thinking about like trauma or car accidents and stuff. But, I've heard of people, even like on the rehab side of things, people will be like, yeah, I went to the ER because my back was killing me. And I was just like, why did you go to the ER for that? And, some people's perception of like their back pain is legit. Like, this is an emergency. I need to get this taken care of. Do you see a lot of people like coming in with like very minor things? Like maybe you shouldn't have come to the emergency room.
Oh yeah, a huge percentage of what we take care of is non-emergent, right? There's it's multifactorial. Some of it is just access to care. People don't have primary care doctors and can't get in to see anybody else, and there's nowhere else they can go. And some of that is just what do you feel is emergency to you? And that's hard. We can't talk about everyone else's subjective feeling of pain, right? Because I don't know how you feel pain. You don't know how I feel pain. So what feels like 10 out of 10 pain to someone might be to us, be like, oh, come on, you came in for that, but it really, that's what we're there for. We're there to take care of any and all comers. So certainly there's a lot of non-emergent things we take care of. Your toe pain for 6 months, maybe didn't need to come into the ER at 4 a.m, but nevertheless, that's what we're there for.
Is there a moment when you have with a patient where you're saying, hey, maybe next time if you experience this again, talk to this person? Or is it more of just like, you got to get in, you got to get out and get to see the next patient?
It depends on what it is, right? I mean, I think for what it's worth, like a good example is high blood pressure, right? Everyone thinks that if their blood pressure is high, they're going to have a stroke like today. I don't know where this came from, right? And that's not how blood pressure works. So blood pressure does its damage over many years, but they see a number, or sometimes they call their doctor, and their doctor says, "Well, better go to the ER for your blood pressure." I am not a specialist at taking care of your chronic blood pressure, and that doesn't mean I don't want to take care of you. It just means I am not the best person to take care of that. Your primary care doctor is a specialist at taking care of your chronic hypertension, dyslipidemia, whatever it is. I don't play with those drugs. I play with a lot more powerful drugs that when you need your blood pressure to come down in a hurry because because you are having a stroke, or because you have bleeding on the brain, or something terrible is going on, I know how to rapidly lower your blood pressure. But if your blood pressure has been 160 over 80 for the last week, your primary doctor is just frankly better at it. So those kinds of conversations I do tend to have. As far as like, it is a fine balance, because you don't want to be like, why are you here? Like that's not what we're there for. We're there to help people,
Yeah.
So sometimes a little education goes a long way. Sometimes it's reframing. Sometimes it's, what are your barriers to care? Well, I couldn't get an appointment for 6 months. Well, that's not helpful, right? So maybe we can give you some referrals to other physicians, other providers in the area. So yeah, long answer to a short question, but that's
I agree. Goes. Yeah. Do you think that's like one of the biggest misconceptions about the emergency department, is just like this, like, well, I can't do anything, I'm just going to go to the ER and see what happens? Or is it, I think in an ideal world, we'd like to think that emergency medicine would be like for emergencies only, but it doesn't seem that way. Is that kind of the biggest thing you see misconception wise, that people are like, they just don't even know what the ER is, and they're just like, I just need to go because this is the only way I can access healthcare?
I mean, I think so. I think, some people think that the ER is just like what you see on TV, right? And people running through the hallways with stretchers and like people bleeding everywhere, and like a lot of times it's not. And a lot of times it's, people don't have insurance, or it's people that really need help, or having psychiatric emergencies, or honestly got too drunk and fell off a roof, that those things do happen. So I think we're there to help people. Like sometimes people joke that we've become the everything room and not the emergency room, because sometimes there's just nowhere else to turn. But yes, I mean, I think a big misconception on one hand is that all we do is emergencies, and on the other hand is that we can handle anything, which is true. We are trained to handle anything, but for what it's worth, maybe we're not the ideal place for that.
Do you think there needs to be like maybe a step before they see you guys? Do you think there needs to be like maybe a line of PAs, or maybe a line of just, or perhaps this already exists and I'm not sure, but perhaps there's a line of people who are like, okay, maybe you don't need to go see, maybe you don't need to be here, you need to go someplace else. Because, well, you can speak on that.
Sure. It becomes a really kind of sticky situation, because we're covered under federal law called EMTALA, where we can't turn anyone away. And this originated because of hospitals that didn't want to take care of expectant mothers because of their insurance back in whenever this, I don't know when the law came into pass, but basically they had bad insurance. So they didn't want the babies to be born at their hospital. So they were shipping them to other hospitals, and bad things were happening, obviously, right? Because these are people about to give birth to babies. So this federal law came into existence because of the situation. But what it says is if you come into the ER, you will have a medical screening exam by a medical professional, whether that be a PA, nurse practitioner, or a physician, and you will be stabilized for the best of our ability, regardless of ability to pay. Right. So if you come in for your 18th, I don't know, cut of the week, and you don't have insurance, you haven't paid any of your bills, it does not matter. So I don't, which is kind of nice from my perspective, because I don't get involved with insurance. Like I when people ask me like, hey, will my insurance cover this? I have no idea, because I don't deal with insurance. I take care of anyone who walks through the front door. So so we can't really like have like a screening person to be like, nah, you can't get out of here, you can't be seen. Because of that, certain emergency departments like have fast track. So for the lower acuity things, they can go there. It's kind of like a mini urgent care. And then some of them have what's called a provider and triage, where someone gets you started, like come in, oh, you just have like, oh, you just need a Band-Aid, we could probably just get rid of you here. Or like, oh, you're here with chest pain, we better get all the blood work and EKG and everything started and send you over to see the physician. So some of the bigger departments have that to help move things, but we really can't just kind of screen and send you away.
Yeah. And I can see how maybe it financially could be an interesting issue, because you have a lot of people coming in, just getting stuff done, and, there's no issues with insurance and stuff. And I'm assuming hospitals are eating up a lot of that cost. I guess, is there a conversation, or at least something that you guys have to do as providers, and maybe you talk with other physicians that you work with to be like, okay, I know you need to see everybody according to law, but I guess I can imagine that it racks up the bills pretty quickly. And so I guess, is there steps in place to account for that? Or I guess, how does that work?
Sure. I mean, so there's certainly certain things on the hospital side for those costs. Like some of them have like charitable funds, and some of that, and there's complicated tax law that's involved depending if you're not-for-profit or for-profit organization. So I don't get involved with that. If there's a certain person that keeps coming in, like, we've seen people that come in 100 times in a month. So if there's that kind of person, we try to recruit social services to see like, what's going on, like how can we help this person, or do they need like a care plan, like if they're coming in for the same thing, this is what we do every time according to protocol. So there's certain things that are done that way. As far as that's how a payer mix works, right? So some of the higher paying insurances will help offset some of the non-paying people, as far as the financials of the hospital goes. But a lot of that's frankly above my pay grade, right? And how those costs get eaten up is really a conversation for an MBA type. But that's basically how it works.
Gotcha. And so how much are you working with other physicians in just a multidisciplinary approach, I suppose? Because obviously, you know a lot about working to get the situation under control and making sure the emergency is basically over. And so I can imagine you're in constant communication with other departments to make sure, like, okay, this person needs to go here, this person needs to go there. I guess, maybe describe the interaction between other physicians during that time.
Sure. So certainly we're kind of the masters of triage, right? So our ultimate goal is disposition. Where are they going to go? Are they going to go home after some stuff is done? Are they going to get admitted to the hospital? Are they going to get transferred to another facility? Where are they going to go? And a lot of times that takes collaboration with other departments. For example, if they need to be admitted to the hospital, we need to talk to either, if their primary care doctor admits to that hospital, them, or a hospitalist service to get admitted to the hospital. If they have a specialty concern, they have a broken bone, we need to talk to an orthopedist. They're having a heart attack, we need to talk to a cardiologist, and on and on and on, right? So we're constant. The amount of different specialties I talk to in a day is pretty much, there's a lot of them. Physiatry, I pretty much never talk to, but other than that, we pretty much talk to everybody. So yeah, I mean, we're interacting with other specialties constantly. For example, social services I talked about as well, case management, sometimes physical therapy. rarely. Like sometimes if there's like, we're really unsure if this person can go home, we could do a pending discharge PT eval, which can be helpful. But certainly, and then nursing and all the other medical people in the hospital we're dealing with constantly. So yeah, you have to be a collaborative person, otherwise you're gonna have a really tough day.
Yeah, and you have to have good communication skills, right? Because if you go over and be like, I have a patient who I don't know, was that something that you had to work on early on, just being able to communicate and effectively be like, okay, this is what's going on, this is who he needs, and this is what needs to happen?
Yeah, I think it depends. Yeah, certainly presenting a patient to another specialty is an acquired skill when you're in your training. Because yeah, a lot of what you said start when you're an intern, you might be like, well, I don't know, I got this guy, kind of thing. As far as collaboration with the other departments, I think I'm lucky that I haven't ever really had much issue with that, because I love talking to people. My wife kills me all the time, stop talking to everybody. But the other part of it is I like to study communication. I think it's very interesting on how we could be better communicators, both to our patients and to our colleagues. So that's part of it as well.
And how have you become a better communicator, would you say?
Well, I mean, the number one thing is that I sit down on the garbage cans when I talk to patients. All right. It's very important. It's something I did when I was in residency. I was really tired because you're working like an animal. And so I would sit down on the garbage cans because I was tired, for no other reason. And then I ended up getting this like award as like patient satisfaction and all these things from the hospital. And I traced it back to just sitting down, because they've done these studies. And if you sit in a room with a patient, they think you're in the room with them like 20 minutes longer than you are, or whatever the number is. It's the perception of that you're spending more time with them if you're seated. And I just did it because I was tired on it, frankly. But after that, I've continued it, and it does make the patients feel better if you're instead of like towering over them, like, what are you here for, coming down, sitting down, tell me what's going on, makes them feel a little bit better. So that's a big one. And as far as like my colleagues and the nursing staff and the techs and everyone else in the emergency department, I just talk to them like I would talk to anyone else, and try to see what their challenges are. It's never like, nurse, I needed this in whatever room 6. But and I like to have my nurses, not my nurses, the nurses, excuse me, call me by my first name. Some of them really have struggled with that. They don't like it, but we're all a team. We're all on the same team. Everybody's the amount of times that a nurse or a tech or a facilities person, et cetera, has saved my butt because they noticed something that I didn't. I can't tell you how many times. And that's because we have a good working relationship. If they were nervous to talk to me, they wouldn't bring it up.
Yeah. And having a team behind you has got to be huge, especially when things are hectic and things are, maybe you have one patient, I can only imagine the things that you're probably dealing with, but in a high tense situation, I'm sure having people who can also work with you to make sure things are going effectively smooth, that would probably help a significant amount.
Oh, absolutely. Even just being able to be like, to one of the nurses, like, hey, what do you think's going on with this person? Maybe it's something I'm not noticing, or like, do you think we should send them home? And then the amount of the discussions that have come from there on something maybe I'm not seeing, but the nurses have been in the room more with them, et cetera, is, it's huge.
Yeah. And for situations where you have maybe patients who can't communicate, or maybe they're just bad at communicating what's going on, how have you tried to improve, at least try to get to the short, concise questions? Like, how has your interview skills changed over from when you first started to now? Because I can imagine when situations have gotten high and things are going on, you got to figure out what's going on, what happened, what do why are you here? Initially, when you first came out of school, it was probably very daunting, and you got to, navigate it. I guess, how have you changed from there until now?
Yeah, I think you get better at asking the right questions. Sometimes you get the older guy and you say, hey, why are you here today? Well, in 1943, oh my God. But a lot of that is like, sir, I'd love to talk about that more, but right now we got to take care of you and your chest pain. And there's a lot of things going on. So let's try to focus on what we're dealing with today. And people understand that, and some of these guys and ladies are just lonely and want to talk. And I try to come back in the room and talk to them a little bit more later. But when you're first getting there, I mean, you got to ask the right questions. I love starting with what's going on. That's my tip. That's my go-to. Hi, I'm Dr. Chisser. Welcome to the emergency department. What's going on? And usually that gets to it. Usually that doesn't start with a story about the lagoon in 43. Usually they're like, well, I got this chest pain. It's killing me,
Yeah.
So yeah, I think you over time, you just adapt and you change your style as far as like what questions you're asking and how you ask them. Because, I don't have very long with each patient. I need to get the critical information.
Yeah. And I think open-ended questions are always the best initially, because then, whatever's at the forefront of their mind and whatever they're thinking about, it's usually probably something that they are really considering is to be the issue. Because sometimes if you say, okay, well, why does your leg, well, at least in my field, if you say, okay, why does your leg hurt? Well, then they only focus on the leg. And it's like, instead of saying what's going on, it's like, well, I noticed when I picked up this thing, I hurt my back, but then, later my leg started hurting. It's like, oh, well, maybe it's the back, and you can kind of go like decipher, okay, is it the back, is it the leg, like what's actually going on? And so I think keeping it open-ended has certainly helped me in my field to try and at least figure out what's actually going on with the patient, because sometimes it's very vague, and like you said, the patient history could go on for quite a while.
Absolutely. And, and then at the end, so you don't get caught off guard, I usually try to end with like, is anything else bothering you? Is there anything else we can address today? So you don't get didn't tell you about, on your way out. So I agree. Open-ended questions are the way to go.
Yeah. And so we kind of talked about how things can get hectic in the ER room. I think on TV shows, they can convey in a way that, they get everything right now. Maybe explain in your own words, like the typical day-to-day of an ER room, and then maybe, explain perhaps maybe getting an MRI in like 3 seconds isn't exactly the status quo of what an ER runs like.
Well, we can order any test, right? Like whether or not we're going to get it is a different question. For MRI is a great example. A lot of people come in and they say they need an MRI and their insurance hasn't approved it yet, and they really need an MRI. An MRI is not an emergency test pretty much ever. There's like 2 or 3 situations I can think of where I need an emergent MRI. Otherwise, not a test for me. And that's when it comes, but that's like the one time I'll mention insurance, because if you came in and you said you've had this back pain for a month and you need an MRI, if you don't check any of the scary boxes for me and I ordered an MRI, that's probably not going to be covered. Right. Because it's just not needed emergently.
What do you mean by scary boxes?
So there's a few things, back pain comes with a few red flags, right? Loss of bowel and bladder control. You generally numbness going down both legs. You can't walk, literally can't walk, not because of pain. If you happen to have special situations where we might worry about an infection in your spine. So those are things that we really need to get an MRI like right now. Everything else, pretty much not. And then certain stroke situations, we need an MRI like right now. Other than that, MRI is hard to get. But like, for example, a CAT scan, if you came in and I'm worried you have the worst headache of your life, and I'm worried you have an aneurysm that popped, you got blood in your brain, I can get that done in like 5 minutes if I need to. So certainly a lot of things can happen quickly. Every order is stat in the emergency department, because presumably we're getting it because we need it right now. So we can get pretty much any test, but the question is whether or not we're going to order that test, right? Your cholesterol panel, I'm never going to order, right? That doesn't make any difference to me in the emergency department, right? But, your blood counts, your electrolytes, I probably need to know about. So that's kind of how it works. It's certainly, we can get things quickly, sometimes quicker than others, but that's not, we're not there because it's taken too long to get a test as an outpatient.
Why is a CAT scan quicker than MRI? I guess for people that don't understand and like what they are, like what is the difference between the two, and maybe even like a CT scan?
Yeah. So CT scan or CAT scan, same thing. Basically I like to describe it as like you pretty much got like hundreds of x-rays all at the same time, and then they're reformatted by the computer. So it's basically an open donut. You go in there and it's like a really fast test, like a couple of minutes it takes. An MRI is all based on magnets and creating data pictures through magnetism. I'm not a physicist, but it uses magnets. And it takes a long time, right? So to get a brain MRI is probably like a half hour, 45-minute test to do. Whereas a CAT scan of the brain probably takes 3 minutes. Those are the tests themselves take a really long time. They're very expensive. Like the machines are extremely expensive. They need specialized people to work the machines, and they also take a really long time to read because you get really detailed pictures. Those are the differences, and that's why we can get them quicker rather than the MRI. And CAT scan, that's like an ER doctor's best friend, right? We can get them quick. They give us really good information. For example, if you come in for we're worried about a stroke, we got to make sure you don't have blood in your brain. You go to CAT scan. 3 minutes later, I can look at the CAT scan and tell you, no, you don't have blood in your brain. We're going to step 2. So those are the nice things we can do with CT scans. MRIs, whole nother ball game, and again, generally not an emergency.
Yeah, and I think that's good for people to know, because I think a lot of the time everyone uses MRI as a gold standard, and I guess in a way it is, but when you're going into the ER, don't expect to go get an MRI. Or if your back pain hurts, maybe, don't get an MRI, go see somebody else first and expect you need that image in order for you to get better, or in order for you to figure out what's going on, because that's not always the case.
Right. Exactly. Usually with the people that come in with back pain, if they're going home, I'll say, well, if this continues, you may need some physical therapy. You may need an MRI down the line. Mm-hmm. But it's not a today situation.
Yeah. And I can only imagine the things you've seen, but I guess, like, do you get a lot of people coming in with like objects in their body or like things sticking out of their arm? I mean, do you have any interesting stories in that regard?
I mean, sure. We all have our like box of memories. Where I work in Batavia right now is very rural, so we see a lot of farm injuries. So hand versus saw versus farm equipment, etc. We see that a lot. When I was working in inner city Chicago, there was more of the stabbings and the shootings and those types of things. And certainly people that get a little frisky in the sexual realm will come in sometimes with things, different objects stuck in different places. So certainly never a dull moment there, but I mean, we see that kind of stuff all the time. And it's tough, right? Cause it's so embarrassing for the patient, right? Like it's not, and they don't want to be made fun of. They don't want to be judged, etc. But like, usually these types of complaints will come up on the board as like private, or, like they won't give you a chief complaint. And then it's, this is stuck at whatever place. But we also see, foreign bodies in the eyes. We see little kids that put beads up their nose and their ears and, all kinds of things like that. So we take objects out of different places all the time.
Orifices.
Yes. Yes.
I remember I watched this one TV show. It was like strange stories of the ER, and this guy had fallen off a roof and a crowbar went straight through his head, and he ended up living to tell the tale. And it was just remarkable. But anytime I think of the ER of like those stories, it's exactly what I think of. I can imagine just like object coming out of every different direction. It's quite I can only imagine some of the stuff that you see, and just being like, okay. And like, how do you keep a straight face in that scenario where like, oh my God, what do we got to do here?
Well, you try to think about the patient in front of you who's having a terrible day, right? I mean, I saw a lady once who had it was like a fish hook necklace, and like she like was in a car and got jostled and it flipped up and got stuck in her nose, right? Like it was just that, like things like that. Like they're having a horrible day. Like they'll probably laugh about it at some point, but for right now, that they're having a bad day. Just get the thing out of her nose.
Yeah. Have you ever had a scenario where you walked in and you're just like, okay, I gotta leave the room for a second, gotta laugh this one out, and then go back in there and be serious?
Oh man, no, I think it's more like what people say that is so shocking sometimes, rather than like the actual. I don't know. Those types of things I don't think bother me anymore, but certainly some of the like crazy things that come out of people's mouths sometimes, like sometimes you just gotta laugh. Like sometimes I'll laugh with them, and because it's just like, what?
Yeah, I can imagine it's at least comic relief can hopefully help them through that weird situation.
Oh yeah.
But with being in high tension situations all the time, being stressful, I'm sure at some points you're like, why am I doing this? And at the same time, dealing with own stress in your own life, I guess, do you regret ever being an emergency medicine physician? Is that something that you enjoy? And I guess if so, how do you manage the stress that comes with the job?
Sure. I mean, most days I do like it. I think when I talk about this a lot on my own platform, but like when I got out of residency, I was really burnt out like almost immediately. Like I really wasn't having a good time. I was working a ton of hours, really high volume hospitals, and just I was really burnt out. That's what it was. And you bring all that home. Like, anyone who tells me that they keep work at work and they don't bring any of it home is lying. I don't think that's possible to separate. I mean, you form walls in your mind to the best of your ability when you see, horrible things happening to kids or people getting shot and stabbed or car accidents, killing people that didn't need, et cetera. Like, luckily, I have my wife who's also a physician that I can talk to, but some of the stuff you can't unsee, right? So when there are days like that, sometimes it's hard. And because the thing is too, you got a bad case. I was talking about this with with the nurses the other day, excuse me, that we had a terrible case come in and then but it was really busy. So we had to just move on, right? And see the next 10 people that just checked in because you don't have time to debrief. You didn't have time to be like, wow, that was really effed up, right? What we just saw. So, those are the challenging days. And that's when, again, like we talked about having a team around you to be able to have a shared experience and debrief and talk about it. But nowadays, I'm happy in my career and most days, yeah. I mean, of course, sometimes you're gonna have a bad day and you're like, why do I do this? This is horrible. But most days I do like it.
That's great. And you're a father and you have kids. And when you first started practicing versus now when you have kids, did your outlook change at all with your patients and just how you interpreted a certain situations, or did that not really change at all in your mind?
Sure. Yeah. So I have a 3.5-month-old now. Okay. And so it changed the way I see kids. Right. I think it's never okay when something bad happens to children, but now as a father, it's so much worse. I don't know what it is. I don't know what the shift is. I don't know if you see your kids in them, but last week we had a really bad case with a couple of kids and it was just it shook me for a week, honestly, so I think when it comes to children and this stuff, that kind of thing ends careers. I had an attending, in residency who decided to switch from emergency medicine to do full-time wound care and hyperbaric medicine because he had a really bad pediatric case and he had a couple of daughters and he just couldn't do it anymore. So certainly I think it does affect you differently when you have children. I don't know, I think it's more just the bad kid, the cases that are bad with children are that much worse.
Do you think that it made you a better doctor in the sense of being empathetic and understanding from a perspective of being listen, I understand, I have kids of my own. Is that something that although tragic, things happening to kids, being a father now, do you think it's allowed you to be more empathetic and at least relate to the patient, or at least the parents?
Yes, I think so. I think also when it comes to adults that have young children that are having bad things happening to them, I think it's also allows you to be more empathetic and more caring, because you can see yourself, in the 40-year-old that's having a heart attack or something like that, and he's got young children. I think of course it's bad no matter what, but I think having a daughter now, I think it definitely makes you more empathetic. Yeah, I would agree with that statement.
That's great. And, you start talking about how career change happened for your one friend, and you started kind of to get into this realm of helping other physicians navigate their own careers. And I guess perhaps explain how you got into, or at least thought of the idea to help other physicians navigate their career in medicine.
Sure. Well, I mean, it all started with my own burnout story, right? So I was having a terrible time. It was every day I thought of something else I could do to quit medicine. I'd be like, I'm going to open a med spa. And then the next day I'd be like, I'm going to do something in the pharmaceutical industry. And then the next day it'd be something else. And my wife was just enough, you got to figure, I mean, if that's fine, if you want to quit medicine and have a plan and you want to do something, but just going from thing to thing every day about how you're going to escape is not helpful, right? You got to be running towards something, not away from something in life. So, I started working with my own mentors, a couple of coaches of my own. And when we moved to Buffalo back from Chicago, I had a plan on what I was going to do to to help design a career that I wanted. And I went after it, and I've succeeded in doing so. And then, some of my colleagues were just like, hey, you're not miserable anymore. Like, what happened to you? And then I started talking to them, and I realized that I was really good at navigating careers when it comes to figuring out what you want, how to get there, and then networking to achieve it. I love helping people get jobs. Like, it's my favorite thing to do. And jobs that matter to them, not just any job. And I'm good at it. And so like I was doing this for a few of my friends and like a couple of family members, and then somebody was like, well, you could charge for that. You probably should stop doing that all for free. And that's kind of where it developed as and it's gone through a couple iterations over time, but at this point, I'm calling myself a career strategist, in that it's kind of career coaching on steroids, right? It's career coaching with actual consulting with people with actionable strategies to get there. So it's a kind of mishmash of it all. But basically I work with early career. I specialize in the early career docs and other healthcare professionals on designing a career that makes them happy and not miserable. So that's kind of it in a nutshell.
Yeah. And do you attribute a lot of your success, or at least changing in the way you do things, to your coaches and mentors that you talk to? Was that something that really kind of shifted you in the right direction?
Yeah, I think so. I mean, I think throughout my training, like starting as a medical student through residency and then early being an attending early, I was always told by everyone else, like it would just get better. Like, it was like grin and bear it philosophy, which I really rally against because it never did, right? It never got better until I made it better. So I think having mentors that were like, no, you don't have to live this way. And this doesn't have to be, you don't have to like, there's a client of mine I worked with that would literally sit in her car and cry before every shift, right? Like that's not normal, right? That's not normal for someone who's like just got out of training, right? So it's yes. So I attribute a lot of it to the mentors of my own that I've worked with, and just kind of my own self-development over time. But it doesn't need to be that way. Like you can be happy in healthcare.
Believe it or not, in case
crazy,
never
right?
think so. I know, it's wild. How did you start to like brainstorm, like, okay, what do I want to do? And I know you started you said you were kind of like throwing ideas and talking out loud with your wife. And did you write things down? Did you say, oh, I kind of like that, maybe I should do that? Because I think for somebody who is in that place of helplessness, they're like, I don't even know what to do. I don't even know what I like. And so did you kind of just start writing down things that you liked, or perhaps areas of like expertise where you feel like, okay, maybe that's something, maybe there's a little bit merit there, and then you started taking actionable steps? Because I think people get confused with, like, they'll say action, like take action. It's like, okay, well, how do I take action to something that I don't know what I want to do? And so I guess, how did you navigate that?
Yeah, a little bit of all that, right? So a lot of the clients come to me like, I don't want to do this. And they're like, well, what do you want to do? Like, I have no idea. Right. So that's a lot. That's pretty much a huge portion of what I do with people, is figuring out what it is they want to do. And, it starts with figuring out what matters to you, like what you care about, what are your core values in life, right? Because if your work is not aligned with your values, you're always going to be miserable, no matter if it's being a doctor or being in the pharmaceutical industry or whatever it is. Right. And then after that, the next step is figure out what your strengths are. Because I don't advocate people trying to fix their weaknesses. I try to have them look for a career that's based in their strengths. So, and a lot of people don't know what their strengths even are. Like if I ask Joe Schmo off the street, like, what are your strengths? They'd be like, oh, I'm nice. Like that's like, sick, right. Dude. That's okay. Well,
you're a good human.
Great. That's wonderful. So like not only what your strengths are, but what are the strengths that actually employers may care about. Right. Whether or not you're a good communicator, is probably important. Whether or not you're able to lead a team or be part of a team is probably important. So figuring out what your strengths are, and then we can start to think about what would be a good fit based on your strengths and your values. And then the next part is creating experiments, right? As like everyone in the healthcare field is a scientist, technically, right? We're all have science-based professions. So you have a hypothesis, go test it, talk to people in that field, talk to people that are doing that job. When I was looking at aesthetics, I went and shadowed an aesthetics physician who had like 3 med spas. And I was like, oh my God, this is not for me.
Explain that, what that is, so everyone
knows. Yeah. So that's like docs that do like Botox and fillers and perhaps like vitamin infusions and things like that. So the really aesthetic medicine, looking good, right? People that do work with people that want to look good. And I was like, well, this is cool, but I can't, not for me. Right.
Yeah.
So you have to develop hypotheses as to what might be a good fit. And then you have to go try and figure out if it would. And a lot of times you're like, nope, cross that off the list. And that's kind of how I worked through it over time. You know, like I like administrative medicine. I always have. I thought that was something I would be good at. And turns out I am, and I do enjoy that. You know, like it's and the thing of it is, like, I also thought I wanted to leave medicine completely, and that's not necessarily true. But I'm a lot happier working a lot less because I have other interests. You know, this is just a part of what I do. And so being able to buy down my clinical time by doing other things has allowed me to kind of like patch together a career that I'm happy with rather than just scrapping it, which is sometimes what people do as well. Maybe you just need a side gig or a monetized business or a monetized side gig or hobby, etc. But that's where that all starts. Like, who are you? And then what are your strengths? And then what are you going to do? Instead of being like, well, let's get to it. What am I going to do?
Yeah. And I guess people are usually stressed with their jobs already. And so how do you navigate people being stressed with their jobs, but then also being like, okay, listen, don't quit your job yet. Like, don't just like jump ship and do something completely different. How do you see people's like minds shift where they're like, okay, at least I'm working on something that I enjoy, versus like, okay, I just have to, I hate my life all the time or cry before every shift, because I think people, the idea, almost think of like a California dream, right? We're like, I'm just going to quit my job and move to California. I'm going to try this thing out. And I can imagine like doctors maybe want to do the same thing where they're like, I hate this. I'm just going to quit my job. And then I'm going to try and figure myself out or figure something out. And so how do you play almost a mediator of balancing the job that they don't like versus trying to find out the one that they want to eventually maybe get into?
Sure. I mean, I think some people do need to quit. I mean, some people are in such a toxic environment where it's like ruining their mental health and they just need to quit. Not a lot, I'd never really advocate for that, but some of my clients have just quit. And we've worked on like bridge jobs to just pay the bills. So there's like part-time work, or there's like chart review things you can do. Like, there's little things you can do on the side to just have a paycheck while you figure it out. But a lot of people, once they start getting into this work and start working towards something, it's like a brighter future, right? They realize that it may take a few months to figure out their ideal career. But while they're working on it, it makes them feel a little bit better about the current situation, or this is temporary while I figure it out. Because what I don't want is them to leave and then get into another job which they hate just as much. Like, that's not helpful for anybody. So while they do this work, a lot of people are okay. They're like, I can't wait to get to the, meat and potatoes of looking for a new job, but, we'll stick it out for these few months. I got to feed my family. Right.
Mm-hmm.
Whereas some people do bridge jobs. Some people have enough financial stores where they just quit, but again, I never push for that. But a lot of times once you get into it, you start doing this work, people, it's means to an end.
And what do you think the biggest complaint is? I mean, obviously burnout is something people throw around all the time. Is it people just don't like what they're doing? Is it stress? Is it, the people that they work with? Like, is it always the scenario where they just don't like what they're doing?
No. So a lot of times people just need a different job. Right? Like, I've met plenty of people that have just switched hospitals or joined a different clinic and are happy. Right.
Mm-hmm.
So it may not be, you may think that it's like you hate emergency medicine or like you hate being a physical therapist or whatever, but maybe you just hate that hospital, that clinic, that way of practicing, or like what I did is cut down and do other things, right? That might be part of it as well. So it is multifactorial. Sometimes it's just like you're not, you don't feel like you're providing help to anyone. Like, you're not helping anybody. You're a paper pusher, or you're just like moving the meat and just trying to make money for someone else. Like, that makes people feel terrible. What is career satisfaction? So like feeling like you're helping people is one of them. Being in a job that ignites you is another thing, right? Being able to like go to work and being like happy about going to work is part of it. Having supportive coworkers and supportive boss is another one. So if the people above you, the administration, is always just like wanting you to do more with less and never making concessions for your work environment, like, that's not helpful. Like autonomy to task, autonomy to your team, etc. Feeling like you have any say, that's a big one. Documentation concerns, like, you can go on and on about what the individual is upset most about. Oftentimes it's not the patients that are upsetting to them. It's the work environment or being forced to do too much with too little. So it really depends. Like it depends on what is causing them to be so unhappy. Some people just chose wrong, right? Like they should never have gone to medical school. Maybe it was dad said you had to go to medical school or something, right? And they're just unhappy, and they'd be unhappy in medicine, and perhaps a non-clinical career would be better for them. But it really depends on the individual, and we get into that once we start working and trying to figure out like who they are as a person. So if it's like I want to make $1 million a year and work 9 to 5 and never have call, like, I mean, I'm not going to say it's impossible. It's going to take some more work. Right.
Right.
But if it's, I like commute is killing me and my boss is horrible, then that's probably something we could do something about pretty easily.
Do you have a litmus test, or at least something to kind of, maybe if someone doesn't know whether, like, they're stressed with their job, but they don't know whether they hate it because they don't like what they're doing, or perhaps they don't like the place of their working, is there kind of a discernible difference or something to look for to be like, okay, maybe it's this or maybe it's that?
Well, I mean, I think it comes down to what's important to them. Like if the place is misaligned with their values, will be a big problem. I also take people through an exercise of ideals and deal breakers. So like you want that $1 million 9 to 5 job, right? But what are your deal breakers? Like I got to make $100,000 a year, and I can't work every weekend or something, right? So there's a difference between the deal breakers and the ideals. If your job has like a bunch of your deal breakers, you're never going to be happy. If it's just a couple of things, if it's like, well, it's not my ideal, but it's not hitting any of the deal breakers, and perhaps it's something we can work with. But those rock bottom things, the minimums you need to be happy at work, those are non-negotiable.
Yeah. And we were talking about earlier how you were talking with your wife and you're saying you're going to do this and you're going to do that. What was the thing that made you actionable? Like, was it the mentor? Was it writing things down? Do you think writing things, because I've read a couple of books. They said that, writing things down and making it physical is something that helps for people to at least take actionable steps towards doing something. Did you find that to be true as well for you?
Yes. Well, part of it was my wife, right? Part of it was like, I don't want to hear about your next plan tomorrow. Like, and she's like, and there's nothing we can do. Like we're here in Chicago. We're going to move back to Buffalo. Like once you get there, then you can figure it out. But like, just think, spend some time trying to figure it out. And so I knew I wasn't going to do anything then and there, so I could start working on this stuff. And yeah, I did. I wrote a lot of things down, a lot of things that came to mind. And I'm a big proponent of writing down your goals, because it's one of those things where if you're able to envision it, if you're able to talk about it, if you're able to write it down, and you write down a problem, the mind starts working on a solution to that problem. It's oftentimes I see with my clients, once they know exactly what they want, like once we go through all this stuff and they figure out exactly, I want to work in this kind of situation in this town doing this, opportunities seem to like come out of thin air, they tell me, which is not really true, right? Because you just shifted your focus to that. It's I forget the name of the effect, but it uses reticular activating system. It's like if you want to have like a red Ford Mustang or something, you're only going to see red Ford Mustangs everywhere you go. Mm-hmm. It's the same kind of effect. Like if you have a very clear on what you want out of your career, you're going to find things that help support that.
How much did you have to do maybe looking into psychology, or at least understanding the way the human brain works in order for you to do what you do now?
Oh, I mean, I do have a background. It's like that was my college major, actually. Oh, okay. But I read a lot. I read a lot about goal setting and goal theory. I think there's certainly a large part of understanding how we tick and what makes us work. Just language, right? Little things like, I don't know how to do X if you add the word yet to it, right? Like I don't know how to transition my career yet. Creates this challenge for the brain, right? It's one of those things, and it's stupid, right? It sounds so silly, but it really matters in how you feel and your outlook on things. So yeah, there's definitely a big part of there's definitely psychology involved, and I think I'm always learning more. I'm always learning new things, and always learning from my clients.
Yeah, I always feel like I have to gamify things sometimes to get things done. Like I always be like, if you do this, then you can get that. If you do this, then you do that. It's like we always have to trick our brains in order to do stuff. It's kind of crazy.
It is, but it works, right?
Yeah, it does. And we've been talking about this burnout, and we talk about how physicians want to ultimately change what they want to do in their career. Do you feel like there's a bigger problem where physicians are working too much, or do you think maybe there's a narrative out there that like a lot of people need to become doctors, and perhaps not everyone's meant to be a doctor, and maybe in high school they were told the wrong thing at the wrong time, and maybe they're just being told this thing like they need to do this, they need to become a doctor or a lawyer or an engineer or whatever. Do you feel like the narrative early on is an issue, or do you feel like maybe there's something that happens between going to school to becoming a resident that there's an issue?
Well, I think not knowing exactly what the situation is, right? I think people that come from like multi-physician household or multi-generational physician, like my wife and I were both the first physicians in our family, so we don't really know, right? Like you know what you see, you know what you hear, but like what's it really like?
Yeah.
I think there needs to be more of that. I also think like colleges and high schools fail in the career development department, or whatever you want to call it, a career advising. I know at one point when I was in college, I was like on this doctor track, and then I was having some doubts. I was like, I don't know, like if this is really right. And I went to the advisor person, and she's like, well, what else are you going to do? I was like, I don't know. That's what your job is, like to help me.
This
And
is
she was
why
like,
I'm
well, it seems like it's just hard right now, so you should probably just keep going. Like, that's terrible advice.
here.
So I would hope that if we're catch people younger, to really, if that are having doubts, or like, yeah, they should, or for example, I know my mom always wanted me to be a lawyer for whatever. I don't know why. Like, we don't have any lawyers in our family. And I went to one summer and shadowed a lawyer, and I was like, oh God, this is horrible. I can't do this. Right. But it comes back to trying to figure out if you like it. And I don't think medical schools too are painting a proper picture of what it's like out there either. People are like, oh, well, residency will be hard, and then you'll get out there and it'll be okay. They're like, well, maybe not. Like, maybe we should learn more about the business of medicine. Maybe we should learn more about like the real world in our professional schools, and not just medical school. It's the same. I see it with dentists and chiropractors and physical therapists like yourself, and every field is like, we're not taught so much about the real world rather than the medicine of it. So perhaps the people are going in for the wrong reasons. Perhaps there needs to be better education in that regard. Or the other part of it is what's going to happen to the system. Will there be systemic change? Because we're seeing the largest exodus of young physicians in the history of time from the profession. So like, what's going to happen, right? Like, who's going to take care of us when we're old if people keep leaving? So I think that's a totally different conversation. But I think medicine inherently is going to have to change in this country the way it's practiced, because it is a bit of a bubble, and there's too many, there's too many inequities, and there's too much disparity of care in this country, et cetera. But that's like a whole different situation, and there's better people to talk to than me.
Well, just a little bit more. Like, why do you think there's this exodus away from physicians?
People are burnt, right? Like, you come out now with like $300,000 to $600,000 in debt, right? Potentially.
That's it.
Yeah. Paid off in a year, you're rich. The reimbursements are going down. Respect for the profession is at an all-time low, which was only exacerbated by the politics in the last year and a half. And people are being expected to do more with less resources. There's all the insurance companies are dictating care a lot more, which again is something nice I don't have to deal with. But we're seeing all that with, you need to document everything within 24 to 48 hours, but you need to check 85 boxes instead of just writing what happened, right? In order to get paid, et cetera. So I think people are just fed up with it, right? People just don't want it. This is like not what a lot of people signed up for. And that's why my whole platform is creating a career, right? Like, you need to design your ideal career, because no one's going to come give it to you. Because if you just went through the traditional path and you took a job and you're miserable, well, a lot of the jobs are going to be like that, right? You got to figure out how to be happy, or you need to leave, and that's okay too. But that's some of the things we're dealing with now. And not just physicians, it's across the spectrum of healthcare.
I know there's a lot of aspects that probably need to be changed, but I guess, is there one that you really think in the back of your mind, you're like, this is probably at least one of the main factors that's driving this issue? And with the goal of my podcast, I want I want people to have better access to physicians, doctors, everything, and I think that's really important. And I think access is certainly a huge issue, and people's barriers to entry are insurance. And so I guess, what is your perspective on what do you think is the biggest factor that needs to change in the next couple of years to perhaps shift what's going on?
Well, insurance is the problem, right? It's been the problem. Access to care is pushed by insurance, and when you have a multi-billion-dollar industry, when you've got people like the big insurers like posting huge profits during COVID, et cetera. Whereas hospitals are losing hundreds of millions of dollars. Doctors are getting laid off. Other people are getting, this is the problem, right? We don't have, if people have to come see me because they can't get in to their doctor, or there's no doctor in town that takes Medicaid, and the one that does use a 6 to 8 month wait, right? Like, how are they going to get help? And then the thing is, like, insurance companies are practicing medicine without a license, right? Because they're telling us what we can and cannot do as physicians. So that is the problem. The solution, I don't have a solution because the proposed solutions all have their flaws. And I think there's certainly people that are much more educated in this situation than I, but I think we see people, we see like African Americans and Latinos dying at much higher rates than whites in this country because of access to care. I mean, look at COVID, look at the health disparities in COVID. It's just, it's a huge overarching issue, and access is the biggest problem. And I think access comes from insurance concerns.
Yeah, it is. It's definitely scary. And during COVID, you had to have seen quite a bit. There had to be a huge change with what you did. I guess maybe describe what it was like to work during the pandemic as an emergency medicine doctor.
It was scary. It was scary and frustrating. I mean, in the beginning, we didn't know what was happening, right? So we were seeing the terror that was happening in New York City. And luckily, my organization did a great job to prepare us as far as protective equipment, et cetera. But we were all scared for ourselves and our family, right? Like, I didn't want to bring something home to my wife. And my wife was able to work remotely. She's a rheumatologist, so she could do telemed. Like, I can't do telemed. So, we were scared. We were like, because we didn't know, these are people coming in, sickest patients we've seen in years, and we have no treatments, right? Like, we have no way to help them except support them. Like, and then we were constantly worried about ourselves. Like, my in-laws live with us. We didn't see them for 6 months. We like barricaded them into their own house. Like, I would like change in the like garage and like, but we were always in the back of our mind was like, is today the day like that I get COVID and bring it home? My wife and I were like, well, I guess we need wills, right? We need to talk about what's going to happen because I'm her biggest threat. And that was and then, as that continued and we started to learn more about COVID and what to do and et cetera, then we have the people that just don't believe that it's real, right? And that are, I remember a patient being like, I hope you're right about this. This seems like pretty overblown. And we're like, that's a slap in the face to everything I do. And we're seeing it continued with the vaccine hesitancy, right? Because now with the new variants, it's pretty much a preventable disease. Right? COVID is as it stands right now. If you're getting sick and dying from COVID, that could have been prevented, generally speaking. So, I feel it's my duty to try and get people vaccinated, right? I ask every patient, and a lot of them are not vaccinated. And it's just I don't trust the data, or I'm not going to take that poison, or I don't want to get sick, or, the crazy, like the microchips and all the like wild theories, et cetera. But, so COVID's been a wild ride, and it hasn't been a pleasant one, that's for sure. Luckily I never got sick. I mean, a lot of the nurses in the hospital had it, it's just, and some of these people like still can't walk like at the speed they used to, or can't walk a city block without getting winded. So this isn't, well, they didn't die, so they're fine kind of thing. So COVID in the emergency department was not a breeze, not fun.
Yeah, I can't imagine. How did your response change? I know initially there was a lot of talks about the ventilators and making sure people can breathe because obviously they couldn't. And I guess how did the emergency response change from the beginning to maybe now?
Well, I mean, again, like I work in a hospital system that has a lot of resources because there's 5 hospitals. So we were able to divert wherever we needed to. If one hospital was getting killed, we were sending gloves and masks and gowns to them and et cetera. So we were able to shuffle a lot of that around. There was lag time between the initial surge and when we got our surge. So they were really able to prepare well. That was great. But I mean, the amount of different types of gowns and things I've worn over these last year and a half, I think I've tried every kind they ever made. But so that, and we've learned more, about what is really a risk and what isn't. But it was all like every day was something different. Like you'd get an email like, oh no, we're totally changing the procedure. And then it would be like the next day, like, oh, we're totally changing it again, just based on new information. So, now I think we have a pretty steady handle on what to do and what not to do, and what therapeutics may work. But yeah, it's been interesting.
Yeah, and are there other therapeutics? I know the vaccine's huge. I mean, we got getting people vaccinated is really important. But are there other therapeutics for people who are just completely hard-headed in the fact that they're not going to get it? Is there something that perhaps that we can do to help protect people, or are there other therapeutics for people who gotten it and need help in that regard?
Well, for people that are sick with symptomatic COVID, I mean, there's steroids seem to help at this point, but again, it's protecting their breathing and supporting them. What everyone can do is continue to wear masks. I mean, that's the biggest thing, vaccinated or not, because with the Delta variant, we're starting to see spread from vaccinated asymptomatic carriers to unvaccinated people. So the Delta variant is pretty much going to rip through the unvaccinated population. I continue to mask wherever I go and try to stay away from people. That's the more, it's people don't want to do it anymore. I mean, and I get it, but that's all we can really do. And try, if you have friends, if you have family that haven't taken the vaccine, like try to show them the data, try to have a conversation. I know sometimes it's very challenging because people get really like heated about this situation on both sides. And that's not helpful either for us to be like, yeah, you got to get it, so try to have a conversation, try to point them in the direction of resources that may be helpful. But vaccination's our best weapon.
Yeah. And I think it definitely didn't help last year, considering it was like an election year, and people got very political very quickly about every little thing, and I think people need to have better conversations nowadays, just being able to understand someone else's point of view, and just being able to even if somebody's doesn't agree with you, you can't get mad at them, and you need to be like, going into a conversation mad or angry at that person is never going to be a way to change someone's mind. So hopefully, as people have more conversations, as Delta variant hopefully doesn't spread as much as we think it may, people are having a little bit at least better conversations and be like, listen, like we need to do something about this. And having conversations, I think, at least is the first step to changing people's minds.
Yeah, the best response you can get is, I've never thought about it that way, right? Because then at least you've gotten, even if they're not like, yes, I'm going to go get vaccinated, at least we can start having conversations where we start to at least expose the other point of view.
Yeah, for sure. And with your audience, you have your own podcast as well. Most of it's focused on helping physicians, I guess. Talk about your podcast so more people know about what you do.
Yeah, thank you. So it's called Talk2MeDoc, talk, the number 2, me, DOC. And it originally, the first season of the podcast was about communication, in fact, between the different specialties of, the different fields of medicine. And then it shifted in focus as my focus shifted to talk about early career physicians and the struggles that we face as a group. I've been told recently that it really applies to early career professionals in general. So some of the things may be only related to physicians, but certainly others professionals have student loans. I want to talk about real estate, want to talk about, savings and retirement, want to talk about, insurance issues, et cetera, and legal protection. So I bring on guests from all around healthcare and beyond healthcare just to discuss issues related to the early career physician. But again, it can be expanded to the early career professional, just kind of skip the physician only episodes. But so that's what it is.
Yeah, and I saw I saw the legal one. I thought that was interesting. I haven't listened to the whole thing yet, but that was certainly, I mean, great information and just stuff. And like you said, early career stuff for any medical provider. I think everyone kind of runs. You don't have to be a physician to be burnt out or to feel stressed about the job that you do. And there may be information on there that you can benefit from and be like, okay, maybe I don't have to do this job, or maybe this isn't this isn't the hospital for me.
Exactly.
And so I kind of want to get to one last thing here with you, managing stress, managing all the stuff that you do. What's your relationship with exercise?
Not as good as I want it to be. Yeah, no, I have, again, I have a little baby, so that makes it a little more challenging.
Yeah.
I've always loved weightlifting. That was kind of my thing. I've got a great setup in the basement. I just got to get down there. It's one of those things. My brother-in-law, he's an attorney, and so we would lift together all the time, but he's been just annihilated at work too. So it's like, just haven't not the loss of accountability has really been troublesome, like I think for both of us. And then I like playing tennis. As far as like cardio stuff, we got one of those Peloton bikes that like my wife uses that I really should get on as well. But the baby kind of threw a wrench into things. I gotta like bring her down there and watch her while I'm lifting or something. But that my relationship with exercise goes up and down. I grew up really not exercising at all. Like I wasn't in a family that I did a lot of exercise. I was like fat kid all through that. And then through college, one time I was like getting out of my car and got winded, and I was like, oh my God. So then I was like, this is it, I'm done. So like my buddy and I joined CrossFit at the time, and like it was new then, and it was like I lost like so much weight. It was the best I ever looked and felt in my life. And then medical school, I still lifted a lot. And then, but the cardio kind of dropped off. And then residency was just like, I don't even know, that was a black hole. Yeah. Who knows what happened? But yeah, I'm trying to get back into it. I'm trying to do little things now that the baby's getting a little older. Even just like, I bought a kettlebell the other day. I've just been swinging that around a little bit when I have a few minutes. So my relationship with exercise needs to improve. I got to talk to it a little bit more, and we got to have a sit down conversation.
Yeah. I think you guys need to have a nice intervention here soon.
Mm-hmm. I agree.
And I think I think a lot of people even during COVID, I think that's something that people didn't highlight maybe enough. It's important that we need to mask up and we need to do things like that. But one thing that wasn't talked about enough was just exercising and staying healthy, or finding at least ways to stay healthy. I guess from emergency medicine doc, you were in the thick of it. Is there things that you think is it mostly being healthy is probably very helpful to build the immune system. So I'm assuming that, being more fit and taking the right vitamins, or at least taking, perhaps supplements that can help you to stay healthy will probably help at least your outcomes, or at least avoid the hospital together, like perhaps together.
It's not going to hurt. I mean, certainly a better immune system is going to be helpful for a virus that is highly contagious. Certainly the people we see the worst outcomes with the obese and the people with comorbidities. So I think, and obesity seems to be the worst risk factor at this point. So yeah, I mean, staying healthy, exercising, people that live in my part of the country should definitely be taking vitamin D supplements. Things like that, or even just walking, right? Like going around the block a couple times, the little things, you don't have to be a CrossFit star, but, and I'm preaching to the choir in myself here, but yes, increasing your vegetables and trying to drop some of the sugar and exercising more, all helpful. And avoiding some of the long-term disease that I take care of to try and keep you out of my department, if possible. Right.
Yeah. No one wants to see you and Andrew, just because, if they see you, it's probably not a good idea. They're probably not.
Well, I tell people all the time, I'm like, I'd love to run into you on the street, but like, don't come in here, man. I don't need to see you here laying on the bed.
Right. No one needs to see you.
No.
Well, anyway, we're getting down to the end here, and I kind of want to close out with a couple final questions. And I gave them to you ahead of time, so you kind of had a good idea to think about them and think about what you'd say. And this is the Health Me to Health You. And the first question I'm going to ask you is, if you had everyone in the world's attention for 30 seconds, what would you say?
Well, I think I would say that you can be happy at home and you can be happy at work. I think this is not just for medical professionals, right? Career affects every aspect of your life. So you need to design a career that makes you happy, because you will bring it home. It will affect your relationship. So be happy at work.
That's great. That's amazing advice. And if the second question is, if you could change one thing about the healthcare system, what would it be? And we kind of talked about this already, but perhaps you had something else in mind.
No, I think access to care and insurance concerns are the biggest issues with the global healthcare system right now.
For sure. And how do more people reach out to you, at least know about what you do? Because I want everyone to, listen to your podcast as well. And, if they have any other, if they're a physician or someone struggling in the healthcare space, at least access to you. So tell more people about where to find you.
Sure. So I'm globally found on my website, andrewtisserdo.com, where you can find the podcast and links to all my social, etc. I just started playing around on TikTok, so that's kind of fun. But I'm on all social media as either my name, Andrew Tisser, or Talk2MeDoc, Talk the number 2 me DOC. Reach out to me on any of the platforms. Twitter's kind of my personal, where I talk more personally to people. Everything else is more business related, but there's plenty of great career advice on there, and feel free to reach out to me. I'm very responsive on all platforms.
You dive deep into the Twitterverse?
I just like it, like for fun, you know. I like hang out. I spend too much time. I just started this yesterday. Is that like I turned all social media notifications off, and I'm only going on there like 3 times a day, because like you get lost in there, man. You could be like, oh, where did the last 2 hours go?
Yeah, I have the same issue only with Instagram. For some reason, it's just I put them on the far screen on my iPhone, so that way, and I put them in like a little box, and I label them like demons, so that way I don't try to like go to them, like every now and again. But it's certainly tough.
Well, thank you for having me, and for your great show and everything you're putting out there into the world. It's very much appreciated.
No, thanks for coming on. I really appreciate it, and taking the time to spend time with me and telling people about more about what you do, and hopefully help more people. Right?
That's it.